Should we go ahead, Artie?
I think we should go ahead and start, yeah.
Okay, great. Good morning, everyone, and welcome to the breakout session entitled Using Population-Based Data for Secondary Analysis. My name is Allie Kempe, and I'm a pediatrician and a health services researcher by training, and I am the director of the Accords program. I'm going to be talking in the second half of this before the activity we do together. And so I'm going to turn this over now to Artie Davidson.
Good morning, everyone. I'm Art Davidson. I'm a family physician and I work also at Accords, and I've spent most of my career at Denver Health. I wanted to start out by just letting you know that there are 3 bulleted learning objectives. They're slightly different than what might have been in some other postings, but just that we're going to be working on these primary areas in this session. And here's the outline for the session. We're going to start just a little comment around the analytic plan, a brief introduction that I'll give to secondary data and some secondary data example databases, and then Allie's going to talk, as she said, about immunizations, and we'll have a little interactive session. I think in preparing this talk, it was clear to me that this reminded me of a quote from Mark Twain, which is, I didn't have time to write a short note, so I wrote a long one instead. Because Allie and I probably could speak for the entire length of this conference about each of our topics, and boiling it down into 35 minutes is not an easy task. So bear with us. But the most important point probably from this talk will be that if you organize yourself well, if you think of a research question well, you can create an analytic plan. I think many of the things that David Vogt just spoke about will be kind of played out in this talk, that we need to think about what we're trying to get to, what the real question is, and then see if the data line up with what you want to ask. So in this talk, we hope that you'll spend a little time thinking about a research question of interest to you within your own focus area. Listen to the short presentation, and then maybe later on, look to this analytic plan template that we've shared with you on the website. But consider in this talk, what might be a secondary database? And maybe you could just put a note in or write something in the chat about what your question is and what kind of secondary data you might be considering. And think about whether the unit of analysis, the unit of measurement is exactly what you're looking for in the data set, what data would be required, whether the right target population is there, or whether there are issues of privacy as you think about trying to answer a question of interest to you. And then you can look at, listen to Allie as she talks and think critically about the potential to use that as an example for how you might proceed. So I'm going to dive in here. What are secondary data? Well, hopefully you are aware, but that is primarily the data that's collected. The data that were collected for some reason somewhere else, and you've decided to use it for your purpose. So the primary purpose might have been, as in David Vogt's talk, was EHR data for patient care, but it could be other types of data that are available to be used for a second reason. Some of those other types of data might be administrative data, claims data, all-payer claims database, or Medicare, Medicaid. But there are many official statistics, government-related data that might be vital statistics, birth and death records. Allie's going to talk about immunization information systems, communicable disease registries, but there are other federal data that are collected, the American Community Survey from the Census Bureau. The National Center for Health Statistics has a long list, as does the Agency for Healthcare Research and Quality, of data sets that they maintain. And there are many other routine statistics like those collected for hospitalizations, and in particular, the Healthcare Cost and Utilization Project and the state inpatient databases that are available for analysis that I think Dr. Vogt spoke to. What's the value of the secondary data set? Well, typically they're very large. They could be very large in geographic spread, national. Sometimes there's state samples. State sampling techniques are often used, but many of the data sets from the National Center for Health Statistics are more at the national level and only able to analyze it at a regional, like 4 quadrants of the country. They're often population-based and have excellent sampling methods to decrease the bias that might happen if you just take whoever is easily accessible to the survey method. And they're often much less costly than primary data collection. So there's a lot of value there. And they have these advantages with some caveats. They're low cost as long as you don't need to wait to get the data or merge it or correct it or impute missing values. That adds to the cost. There's a large N, but sometimes you may be looking for a specific subgroup and you're not able to really find the right number of people for that subgroup in the large N. Or you may want to do it about your state or county, and that's not really available in some of these national data sets. They're representative as long as you know who's gotten into the database. And I think Dr. Vox spoke about this. EHR data is great, but it's only for those who access care. You don't know how long they'll remain in that system and whether they've gone to another system and maybe you're missing subsequent events somewhere else. And they can be timely as long as you have the skill to access that and you have the expertise to analyze that. So there are some caveats in terms of their advantages. And there are definitely some disadvantages. They're not always collected for the research purpose that you are looking at. And so therefore there may be some data inaccuracies or inconsistencies for the type of work that you're trying to do. They may not be collected at the proper time points that you might need for your study, rather than your needs. They've addressed some other need that was maybe not considering a time-dependent variable that you might want to study in your research question. There are relevant events that may not be collected in a specific data set that you'd like to have. You might have almost everything, but for instance, in this circumstance, some data sets will not have hospitalization, so that would be something you would be missing. The missingness may not be random. You may have absence of precision or severity or detail that would be important. So you might only have an ICD-9 or 10 code rather than some marker of severity. You may have difficulty controlling for bias or effect modification. Hopefully you can find ways to do that, as Dr. Vox spoke about, in your analytic approach. There may be issues of access, privacy, data sharing agreements may be required to get to see some of the data. And you can also see that there's so much data you can be at risk for drowning in it. If you haven't got, as we were started out talking about this analytic plan, a clearly formulated hypothesis. And you could be the prisoner of your data. You may find that you have the right answer to the wrong question because you were unable to answer the question you intended to study. So what might be required? So if you decide to use any of these data sets we'll talk about, few of them come prepared with immediate access by your favorite application. Getting your data in the appropriate format for the analysis is often complicated. You may be good at SAS, but you're going to need to use those SAS skills to get it from whatever format it is into something that you'll be able to use effectively with your analytic team or approach. And organizing the data is often the most difficult part of the work using secondary data. It's even more complex than the most complex statistical analysis. It takes a methodic approach, and that's why we share with you the analytic plan template that's at the website to help you organize and think through some key points as you begin down this path. The greater specificity you have in your research question reduces the time it takes to organize. When you use secondary data, you should define that question, as we said, and what are the tested hypotheses that you may be looking toward. And there are several types of data, and we're going to be focusing on the second bullet here, extensive, complex data such as population-based surveys. And here's a second handout that we have, secondary data sets, that describes many of the data sets that we'll just be briefly touching on in just a few slides to make sure that you have a little more info as you approach them. All of them are accessible on the internet. Assuring that you have the proper data to address your question is essential as you move forward. So the things that you want to, as Dr. Vox spoke about, you want to interrogate your data. Ask about these factors when considering your secondary data source. Is it the appropriate unit of analysis? Do I really want to ask a question about a patient or a provider's practice or about systems? And each of the data sets may be particularly tuned to one or the other of these. Sometimes they'll cover several, but they usually tune to one of them rather than all of them. Think about the sampling methods. Were they population-based? How do they assure that they were getting the right number of individuals from a variety of subpopulations to be represented? Are the variables consistent with your goals? Are the values of those variables stored in a way that you're able to use them? And is the level of measurement appropriate to your question of interest? Here are just some typical data sets, or actually sources of data. There are 4 of them we listed here. I think that the CDC generally focuses on, this is just general, it's not an absolute here, behaviors, diseases, and outcomes. The CDC also has information about care at the National Center for Health Statistics about care and outcomes. At HRQ, the Agency for Healthcare Research and Quality, they focus more on cost and quality and safety. And lastly, an important source from the feds is the census data, which allows you to calculate the base population, often down to the census tract level. And they conduct these surveys between every 10 years, the American Community Survey, which allows you to make population estimates and study other variables around populations in the inter-decade period. When you're looking for the data, you'll spend less time on what the actual computer work is and more on, does this, as I've mentioned, suit the research needs? This is a time-consuming and meticulous process of searching through what's on the web, what sort of information resources are available associated with each of these data sources. You should use the online tools, their knowledge bases, and experience of others to assist in this process. There are steps along the way, several steps where you may say, oh gosh, I wish I knew that earlier. Those sort of gotchas. So be methodic in your approach. Give yourself plenty of time, not only to locate the data, but to review and archive any associated materials and keeping the materials in an organized fashion, as again, using that analytic plan. So, and any technical documentation you may receive off the web or code books there. Accessing the code books, they're typically up on each of these sites. It usually talks about how data were collected, the sampling design, the variables contained in that data set, any surveys or instruments or questionnaires used to solicit the answers from respondents so you can see exactly what question was asked, and the format of the variable or its location as it's stored in the raw data file. Most codebooks also have a section on how to read it, what a data dictionary is, and what those instruments are, as I just mentioned. So just to quickly say, before we get on to Allie's example, there are these data sets from the National Center for Health Statistics. They have population health surveys like the Nutrition and Health Examination Survey. We'll talk a little about that later. Vital records. You can see here some of the things that Dr. Vox was speaking about, and many provider surveys from different sorts of practices, ambulatory, inpatient, post-discharge, post-acute care. All those resources are available in the National Center for Health Statistics. Another agency under HHS is the Healthcare Research and Quality Agency, and they have here, as I mentioned, their focus on cost, healthcare cost and utilization project. They have inpatient databases, the medical expenditure survey, a variety of resources based on quality, on readmissions, on emergency departments, and even topic related like opioid related hospitalization. So a wealth of information from the AHRQ. And lastly, from CDC, you can see here many things from the National Center for Health Statistics on the other slide: injury and violence, diseases, vaccinations, some of what Ali may speak about, smoking, tobacco use, pregnancy, and disability and health. So given that rapid introduction, now we're going to kind of use a little bit of Ali's expertise and lived experience in the information and immunization systems and share with you a real world example. Thank you. Here we go now, Ali, and please just tell me when to advance.
Okay, great. So as you can see, we're trying to consolidate a huge amount of information very quickly. I'm going to give you two examples of using slightly different types of data than what Artie just described. And that is data that is accessible, well, not easily accessible, but accessible at the state level. And it's sort of a living data set. I'm going to focus on immunization information systems, and that is more commonly known as immunization registries. These are confidential, population-based, computerized databases that try to consolidate all of the immunization records for individuals across a geopolitical area, and that's usually a state or region. And these IISs are capable of bilateral exchange of immunization information with all kinds of immunization healthcare providers, including pharmacists, to try to consolidate all records for individuals. There are 62 state or regional IISs in the US. So every state has an IIS, and some states with, for example, very large metropolitan areas like New York have both a state registry and a city registry. So there are more than, obviously, the number of states. Importantly, each state or regional jurisdiction makes its own decisions about how CDC standards are interpreted and implemented, and that's important. So I'm going to use this as an example. There are other state databases that would be similar to this, but it's not the same as what Artie described, where you go online, you find a national survey. Thank you. So other important things to note about these types of databases: state laws and regulations differ with respect to important parameters such as privacy, how you access the data, whether reporting of vaccinations for different age groups is mandated. And as you can see, that would have a huge impact on completeness of the data. How people are included in the registry. Does it require implicit consent, explicit consent? Can people opt in? Can they opt out? And in addition, what kind of statutes exist for outreach from the IIS, for example, to do a public health intervention? So these types of things have enormous implications for completeness of the data and for what kind of potential interventions you can do using the IIS. IISs also really differ with respect to the degree of HL7 connectivity with practice sites, and that's the bilateral receipt and transfer of data. And that, again, has really important implications for the completeness of data and for how up to date at any particular moment that data set is. Next slide. Next slide, yeah. And in addition, what can you do with IISs? So one of the interventions you can do is reminder recall. And that's the use of different modalities, most often, honestly, phone or mail, to remind patients about either upcoming immunizations that are due or to recall them for immunizations that are past due. About a third of states have a specific legal mandate that say they can reach out to all populations. 11% only to certain populations, and 62% have no legal mandate. So it's up to interpretation whether the state health department is allowed to reach out to do reminder recall. There's also some other federal things that are very interesting. The FCC implemented the Telephone Consumer Protection Act, or TCPA, and there have been a number of additional restrictions in the years that followed on calls and texts going to cell phones. So a very interesting thing about working with the CIIS is that the interpretation of the TCPA varies by state. And interestingly, even within a state, it varies by jurisdiction. So that you can be in a situation where the TCPA interpretation at the state level is one thing, and that a different county is another. So again, if you're going to do something like phone reminder recall as an intervention, you have to pay attention to that restriction. Next slide. So I'm going to focus now on Colorado's CIIS, which is called CIIS. And, based on what Artie said, the first question is it a useful secondary data set for my question? And it depends on the question. So for us, we were looking at children. So how complete is the data set? Very complete. 85% of vaccines for children, according to data from 2019, are in CIIS. All children less than 6 have an immunization in the registry. Colorado is an opt-out state, so birth certificate data are automatically used to populate CIIS. All babies go into the CIIS registry, and parents have to go into their provider and opt their child out to be not in CIIS, and very few parents even know about how to do that, and much less do it. Now, if you were going to focus on an adult question, very different scene. The adult data are really very incomplete unless you specifically stick with the public sector. So our question is about kids, so it's okay. So how up to date is the registry? All public sites and the majority of private sites have HL7 connectivity with rapid or immediate upload of immunizations. So it's very good. Can it be used for outreach interventions? CIIS has statutory authority to conduct reminder recall. So that's an intervention you can do with CIIS. Is it publicly available? No. Unless you're a provider, you don't have access to an CIIS because it contains medical, personal HIPAA protected information. However, if you collaborate with CIIS, or you collaborate with providers who are using CIIS, you certainly can have access to those data. And in fact, CIIS leadership is very interested in assisting with research if it is consistent with their mission and it doesn't increase their workload. And that's a very important if. Next slide. So why would CIIS collaborate? Well, actually, collaborating with us has meant that they've really improved the database. And these are the kind of things to think about when you're trying to entice somebody at the government level to play with you. Doing research on these types of data sets really improves the completeness of the data because you discover problems and then they're fixed. It also can be a source of funding, and we have provided, for example, direct financial support for CIIS personnel through grant supports. And importantly, for some immunization, for some CIISs, national reputation. CIIS, for example, is recognized as a leader in CIIS research and innovation by national organizations that they care about, like the Association of Immunization Managers. Next slide. So I'm going to quickly present 2 examples. And the reason I'm doing this is most people think of just retrospective data analysis is what you could do with such a data set. And I want to make the point that you can do a pragmatic trial using CIIS, for example. So here's a classic retrospective secondary data analysis. It's very topical. This looks at the number of childhood and adolescent vaccines administered before and after the COVID outbreak in Colorado. And you can just see when, whoops, excuse me.
Sorry.
When that
Going back.
line is when everything shut down and vaccines went way down. So
Trying to get back
was,
there, Allie.
that's
There.
okay. So you can see where that line is. There's a dramatic drop off in vaccinations, and that's of enormous public health significance and very easy to obtain from the CIIS. Okay, next slide. So next I'm going to give you some examples of pragmatic trials that were conducted using CIIS. And the question here is comparing two approaches to reminder recall. The question is CIIS-based centralized recall more effective for increasing population immunization rates for children if it's conducted by individual practices or if it's conducted centrally by the state health department using the CIIS? Next slide. So here we basically, we wanted to compare entire counties. The intervention is the level of the county, and there are very few data sets where you can actually look at data from at the level of the county. So we took 14 counties, we stratified by urban, rural, and we randomized them to two approaches, either a practice-based approach or a population-based approach. Next slide. I'm just whipping through this so that we have some time. Okay, and here's the results without getting into things in any depth. If you look on the right, the practice-based counties, very few practices were able to do reminder recall. So the reach, which is the little blue slice there, is about 5% of the population. If you look on the left, the population-based approach using the CIIS, about 85% of children were reached. Next slide. And here's the outcomes data. The absolute effect differences were 9% higher in the population-based counties for the percent receiving any vaccine within 6 months. Next slide. And importantly, the costs were far lower in the population-based counties, $10 compared to $38 for the receipt of one or more vaccines. Next slide. So we've done a lot of other trials in this way. We've looked at ways to improve it by including the practice name on the messages. We've looked at the effectiveness among adult populations if the database can be populated within a system. We found that centralized reminder recall doesn't work very well for vaccines when there's a high degree of hesitancy on the part of the population. And we found that it's more effective if patients or parents can choose the method they want to be contacted by. Next slide. So one question is, could I have used a national database like National Immunization Survey for these examples? And the answer is no. Example one required longitudinal daily, weekly data pulls so that we get a snapshot over time of immunization delivery, which NIS could not do. Example two required immunization levels at the level of the county and at the level of practices, and data pulls needed to be timed with respect to the trial. So NIS wouldn't have satisfied either of those criteria. Next slide. So working with an IIS requires a collaborative relationship that benefits both partners. And you need to, as I said, assess the completeness and deal with legal and privacy issues. I'm going to stop there so we have some time for the interactive component, but just whipped through that as two examples.
Thank you, Allie. So I don't know that anybody has entered anything into the chat, and I'm hoping that maybe we can have a little discussion about, you know, in your research question, can you identify what that unit of analysis is? Can you identify how often, as Allie pointed, how often the data might need to be collected for that question? And I'm not going to touch the screen and look at the chat. So maybe, Allie, you can do that, because each time I do that, it advances the slide.
I do not see any questions.
Note in,
I don't see any questions in the chat.
So,
yeah.
yeah. So maybe you're all a little bit bashful here. So Allie and I did have a couple of questions that we put on the handout, and I'm going to advance to the next slide. So there were a couple of questions that we just posed, and these were done without really thinking about the data sets in particular. It was done well in advance of this session. So the first one was, among patients diagnosed with appendicitis, is hospital readmission higher for those receiving initial antibiotic therapy alone compared with patients receiving initial surgical intervention? So last night I spent a little time just thinking about this question and looking through the data sets. So here, there's this question, and I went to the source that I would think might have something about this, AHRQ. They had two data sets that one, when I looked for the word readmission or appendicitis or antibiotics in the healthcare cost and utilization project, the quality measure data set had a post-operative sepsis for every 1,000 surgery admissions was one place where you would find out about outcomes from appendicitis, or in this second data point, admissions with perforations or abscess of the appendix was available also, or admissions below 18 and above 18. And they had another one on readmission database, and you could look that up by ICD-10 code or procedural code for appendicitis. But none of the data sets that I saw really had anything about antibiotic therapy, and you couldn't really tell whether you had a preceding antibiotic therapy in any of these. So from a brief review of the data sets that were available at HRQ, I could not find a way to answer this question. So this is real life. You have a question, sometimes the data line up well and sometimes they don't. And in this instance, so far, unless we speak with some specialist at HRQ who might be able to point us in a better direction, it doesn't appear that I can find that in a national data set. Might be other data sets. Certainly there are other data sets, from EHRs where people or collaborators where they join data sets from various EHRs where you might be able to ask this question, but not in those national data sets. The other question that we had was more around policy or population trends. What were the trends in obesity prevalence that have been observed in the US youth and adults by sex and age during the past decade? And so I did the same thing for that one. This is an easy one for us to answer using national data sets. The National Health and Nutrition Examination Survey is conducted every year around the country in multiple sites, and they actually bring people in to a trailer setup that they bring to each city. They set up 5 trailers, and people walk through and have a number of physiologic measurements made, including height and weight, and then the BMI could be calculated. And that's been going on for probably 40 or 50 years. So you definitely have a way to answer this question, and that's the way that the CDC does this every year. They have a new output about trends in obesity prevalence by age, by sex during the past decade. Another source of data would be the behavioral risk factor surveillance system. In that one, each state is supported by CDC funds to conduct a survey, a random population-based survey, typically by phone. And in that, they ask people what their weight and height is. So it's often a problem, though, that people will misrepresent those 2 items. But that is a source of data as well. And you could do a study there as compared to NHANES, which is a national sample and really wouldn't let you get down to a county level assessment. The BRFSS, indeed, there's sufficient numbers there to do an analysis by county. So you could compare much smaller geographic regions. Now, I think we're probably close to time here, so I'm sorry that no one volunteered a question, but appreciate you all listening, and I hope that the rest of the sessions go well for you today, and thank you, Allie, and thank you,
Mark.
Natalie, for helping us through this session.
Thanks, everyone.
Thank you all. Have a good day.